Okay, it's my pleasure to introduce the last speaker who's going to talk about challenges in the treatment of pediatric chronic myeloid leukemia, and it's Hanafy Hafez from the National Cancer Institute of Egypt, and I apologize for my pronunciation errors.
Bismillahirrahmanirrahim. Good afternoon, everybody. First, I would like to thank the organizing committee for giving me the opportunity to talk today. I will talk about the challenges in the treatment of pediatric chronic myeloid leukemia. Chronic myeloid leukemia is a myeloproliferative neoplasm characterized by the uncontrolled expansion of the primitive hematopoietic stem cells and the early myeloid progenitors. It characterized by three triphasic natural history, starting by the chronic phase. If left untreated, it will progress to the accelerated or blastic crisis, which termed as advanced phase of Cml. Actually, it's a rare disease in pediatric population, accounting for about 2 to 3% of leukemia in children below 15 years of old, and 9% only for leukemia in adolescents from 15 to 19 years. The key molecular background of for development of chronic myeloid leukemia is the reciprocal translocation between chromosome 9 and chromosome 22. If EBL on chromosome 9 transferred or added to BCR in chromosome 22, will form BCR-EBL oncogene, which later on lead to constitutive production of kinase. And we need to know first that EBL, which is a normal gene or normal protein involved in cell proliferation, involved in cell cycle regulation, cellular response to genotoxic stress, and also in transmission of information related to the cellular environment through integrin signaling. So when fused to BCR here, it will acquire additional function related to the formation of the B210 BCR-EBL oncoprotein. We can see here that BCR-EBL oncoprotein will lead to subsequent activation or uncontrolled stimulation to different effector cytoplasmic proteins like RAS, JAK, STAT, which are involved in cell proliferation, cell cycle arrest, cell growth, and apoptosis. So the overall vasogenesis of Cml starts by this translocation 922 and formation of the BCR-EBL fusion gene, which lead to constitutive expression of EBL1, and this lead to uncontrolled stimulation to the effector cytoplasmic proteins here with uncontrolled proliferative signals and formation of chronic phase. We need to know also that chronic phase can last for years with median duration 5 to 7 years if left untreated even without TKI, but with accumulation of BCR-EBL oncoprotein, in addition to increase the exposure to oxygen species and genomic instability with development of clonal chromosomal abnormality, this will lead to progression from the chronic phase to the accelerated phase. And this accelerated phase is very rapidly aggressive phase. If left untreated without TKI, with a median duration of 5 to 7 months, will progress to blastic crisis. And the blastic crisis without treatment, the median survival rate about 5 to 6 months. Typically, the patient with chronic myeloid leukemia may be asymptomatic or can present with systemic manifestation, non-specific manifestation like fatigue, weight loss, night sweat, or characteristically have marked or huge splenomegaly. The peripheral blood of a case with chronic myeloid leukemia can show marked leukocytosis, monocytosis, thrombocytosis, and pedophilia, and the bone marrow will reveal granulocytic hyperplasia with maturation. And to further confirm the diagnosis of patients with chronic myeloid leukemia, we need to do cytogenetic analysis, FISH analysis for a cell in bone marrow using during the metaphase to confirm the diagnosis, and also to do molecular assessment to demonstrate the B210 BCR-EBL oncoprotein in the peripheral blood using real-time PCR. The WHO classification of initial phase of diagnosis at initial presentation defined the chronic phase by confirmation of BCR-EBL fusion gene with bone marrow blast below 10%, with no any criteria of accelerated phase or blastic crisis. And the blastic phase here, to define blastic phase, we should have one or more of the following criteria, like bone marrow blast in the peripheral blood in bone marrow more than or equal to 20%, or extramedullary blast proliferation excluding spleen, or presence of clusters of the blast in the bone marrow biopsy. And recently, the WHO classification added some criteria for accelerated phase CML to be present of one or more of the following criteria: persistent or increasing leukocytosis unresponsive to therapy, increasing thrombocytosis unresponsive to therapy, more than 20% pedophilia in the peripheral blood, from 10 to 19% blast either in the peripheral blood or on the bone marrow. But what the most important thing is they added recently any presence of additional chromosomal abnormalities, especially if they are involving the major root abnormality like trisomy 8, trisomy 19, isochromosome 17, or second Philadelphia chromosome to be an accelerated phase, or even complex karyotyping to be an accelerated phase, because it's proved that the presence of these chromosomal abnormalities associated with much more poor response to TKI and more risk of relapse. Also, if any developing chromosomal abnormalities during TKI therapy should be considered as accelerated phase. And lastly, they put a response or provisional response criteria to TKI to be one of the high-risk criteria and need further intensification or shift to the other TKI, so considered accelerated phase. If we have lack of hematological response to first TKI, or resistant to more to sequential TKI therapy, or even developing of 2 or more mutations in BCR-EBL while in TKI therapy. And we can see here from this slide the timeline clinical events in the treatment of CML during the last 50 years. But we can see the most important steps starting from 1960 with the knowing the molecular background of chronic myeloid leukemia with the discovery of Philadelphia chromosome with the underlying molecular background, to in 1970s with the initiation of hematopoietic stem cell transplant as the first therapeutic or curative option for those with chronic myeloid leukemia. Then in 2001 with the approval of imatinib as a first target therapy for chronic myeloid leukemia. And lastly, in 2010, with the approval of second generation TKI like lenvatinib and venetoclax to be used as a frontline treatment for those with chronic myeloid leukemia. CML is one of the best examples that reflect significant steady improvement in survival over time, starting from below 10% very early on to about 60 to 70% with initiation of hematopoietic stem cell transplantation, and to currently 80 to 90% survival outcome. The treatment of CML passed in 2 major phases, pre-TKI era and then post-TKI era. And pre-TKI, the only curative option for CML was hematopoietic stem cell transplantation with best available donor. And hydroxyurea or other options like hydroxyurea or interferon were used only to control the disease before transplant. But post-TKI era, the therapeutic approach of CML changed dramatically, and the survival rate with TKI about 80 to 90%. In adults, it became very clear to start TKI therapy and to reserve hematopoietic stem cell transplant for those intolerant or resistant to TKI or those with advanced stage CML. But in pediatric, there are some issues related to the treatment of CML in pediatric population. The lack of standard guidelines, because most of the guidelines were extrapolated from the adult population or adult guidelines, and lack of initial prognostic scoring, as most of the initial prognostic scoring in adults are not applicable in pediatric population. Also, the treatment goal in pediatric population, we know that there is a long time expectancy of survival in this pediatric population. So we need to target cure, not a disease suppression for those younger patients. And also the role of hematopoietic stem cell transplantation in first chronic phase still of a big controversial issue. The sustained efficacy of TKI and also the safety of TKI discontinuation in pediatric, the long-term side effects of TKI in children and adolescents. I will start by hematopoietic stem cell transplant as a treatment option. From 1980 to 2004, the outcome for hematopoietic stem cell transplant revealed that event-free survival from 60 to 65% when you use matched related donor, compared to 30 to 55% when you use matched unrelated donor. And the overall survival with matched related donor was about 70 to 85% compared to 45 to 60% with matched unrelated donor. But after that time, there was further improvement in the transplant setting with significant reduction of the transplant-related mortality. But this was in parallel to increasing use of TKIs, and which reflected in the number of transplant with TKI. This is the first prospective trial analyzing the outcome of allogeneic stem cell transplant in pediatric and adolescents, and they reported about more than 80% overall survival was either using busulfan-based or TBI-based conditioning regimen, but with matched sibling donor, compared to 50 to 60% with matched unrelated donor. A more recent analysis from the CIBMTR analyzed the outcome of allogeneic stem cell transplant using different donor source and stem cell source, and they concluded that the better survival rate were associated with matched sibling donor and well-matched unrelated donor like 10/10, HLA matching, either using peripheral blood or bone marrow source. And this is the CIBMTR data from 2003 to 2013 using matched sibling donor allogeneic stem cell transplant in children below 20 years of age, and they reported that the outcome of hematopoietic stem cell transplant in those with chronic phase is about 70 to 80%, while it was about 50 to 60% with those with accelerated phase, and only 25 to 30% with those with plastic crisis. In our center, we recently published the outcome of a 43 patient had matched related donor with chronic myeloid leukemia, had available matched related donor, 39 in chronic phase and 4 patients with plastic crisis, 32 patients received bone marrow graft, and while 11 patients received mobilized peripheral blood stem cell, and we reported 5-year overall survival of 97% and the progression-free survival 94%, and the event-free survival was 80%. And we documented 7 patients with molecular relapse after transplant, and actually we salvaged 87% of them and achieved molecular remission either with TKI only and TKI post-donor lymphocyte infusion. And also, as well known that the cumulative incidence of chronic GVHD was significantly higher when those who received the peripheral blood compared to the bone marrow stem cell source. So to conclude here, the hematopoietic stem cell transplant is the only proven cure for CML patient with best result using myeloablative conditioning from matched related donor and best use marrow source with the outcome or disease-free survival around 80%. And the relapsed post-hematopoietic stem cell transplantation can be effectively salvaged by either TKI therapy or donor lymphocyte infusion or both. The second treatment option in chronic myeloid leukemia is the TKI therapy or tyrosine kinase inhibitors, and simply the mechanism of action, this TKI occupy the ATP binding pocket here, the ATP binding pocket of the BCR-ABL, so block the activation of further effector cytoplasmic proteins that cause the leukemic process. But we need to further illustrate how this TKI act and the causes of resistance to TKI. This area, that the mechanism of action of imatinib here, it binds the ATP binding pocket here, and so block the activation of the effector cytoplasmic protein and block the cell signaling and cell proliferation. But with the presence of the kinase domain mutation, the imatinib or any TKI blocked from any binding to this pocket, so it will not block the signaling and cell proliferation. But we need to know also that in this diagram, we can see here that the TKI will suppress the blasts here, but it did not inhibit the leukemia stem cells. So it will left not inhibited. So this explains that with TKI discontinuation, about 50 to 60% will show molecular relapse. So, and which is not the case with hematopoietic stem cell transplant, because we will replace the whole things, the hematopoietic stem cell, the leukemia stem cells, and the blast with a healthy marrow from a recipient, and so it will offer a cure. And also, for this reason, some of the current studies are investigating another targets, especially targeting the leukemia stem cell to suppress their activation, so aiming for cure. So one of the most important issues is the response to Tdi therapy, and there are many methods to assess the response, starting from complete blood count to assess the hematological response, karyotyping using FISH analysis for cells during the metaphase in the bone marrow to delineate cytogenetic response, and RT-PCR or quantitative PCR to measure the BCR-ABL transcripts to assess the molecular response. And simply the definition of different response. To define complete hematological response is the normalization of different count, YBCs, platelet count, and differential with no immature forms, and the basophils decline to below 5% with no bulbar spleen. And the complete cytogenetic response means that there is no Philadelphia during metaphase detected by FISH, and the major cytogenetic response, this means that from 0 to 35% Philadelphia during the metaphase using FISH analysis, and the definition of different molecular response starting from early molecular response, which means that there is a below or equal 10% according to the international scale of BCR-ABL transcripts at 3 and 6 months. The major molecular response defined that presence of less than or equal 0.1% of the BCR-ABL transcripts or more than 3 log reduction from the initial tumor burden. And the complete molecular response, which is variable according to the measuring laboratory center, but usually we will not detect BCR-ABL transcripts if we have more than 4.5 log reduction from the initial tumor burden. So these are the NCCN recommendation for the timeline and the method of assessment of for TKI response, and they recommended to do bone marrow cytogenetic analysis at diagnosis, and if we have a failure to reach the milestones to confirm the failure, and at any given time with suspected relapse like hematological or cytogenetic relapse. While the quantitative PCR using the international scale should be done also at initial diagnosis every 3 months, and recommended to do indefinitely, especially for first 2 years, and till achieving a major molecular response, and we can do from 3 to 6 months regularly after that. But if you have 1 log rise for BCR-ABL transcripts, especially with loss of major molecular response, you should do this, the quantitative PCR much more frequent from 1 to 3 months. And the mutational analysis for BCR-ABL is recommended to be done in the advanced stage CML, blasted or accelerated phase. Also, in any kid with failure to reach the milestones, or if any given time with a relapse or suspected relapse like hematological or cytogenetic relapse. And this trial, one of the first trials that analyzed the effect of imatinib or in children and adolescents with previously untreated chronic myeloid leukemia, and we can see here that about 98% of the patients achieved complete hematological response, while 83 achieved complete and major cytogenetic response, and about 60% they achieved major molecular response, and only 35% of them achieved complete molecular response. A more recent study also analyzed the effect of imatinib as frontline therapy in chronic myeloid leukemia in pediatric patients or in children and adolescents, and they also reported 80% of the cases achieved major cytogenetic response at 12 months, and 60% achieved complete cytogenetic response at 12 months, while about 60% achieved major molecular response at 18 months, and 22 and 15% achieved more than 4 log reduction and 4.5 log reduction subsequently. And this study also reported about 27% of imatinib failure with a 5-year progression-free survival of 97%. and they reported 5 patients that progressed to accelerated or plastic crisis. In Children's Cancer Hospital, Egypt, we have about 86 patients with chronic myeloid leukemia initiated. Well, we have the first line here in Egypt as imatinib, and about 70% of the patients maintained on imatinib due to optimal or suboptimal response, while 21 or 25% of those patients shifted to second line TKI, 4 patients because of intolerance, and about 17 patients because of imatinib failure. And from this 17 patients, we found 15 patients with BCR-ABL positive mutations. And we reported 5-year overall survival of 92%, and the 5-year progression-free survival 90%, and the event-free survival was 77%. And 9 patients from those patients, about 10% progressed to advanced phase of CML, and unfortunately most of those patients died before going to transplant. So the response of TKI therapy is one of the most important prognostic factors, and those who will achieve early and sustained response will have a better outcome. And this is one of the first studies that analyzed the impact of MRD after 3 months of TKI on the outcome, and they reported that those who have below 10% of BCR-ABL after 3 months will be associated with significantly better overall survival than those who will have more than 10% of BCR-ABL transcripts. Many of other studies using different TKIs, either imatinib, dasatinib, or nilotinib, we can see here the 5-year progression-free survival in all these trials significantly better than those who have more than 10% residual after 3 months. And also the overall 5-year survival is significantly better when have a less than 10% residual of BCR-ABL transcripts after 3 months compared to those who have more than 10% after 3 months. One of the issues that was discussed many years, the best front line, especially after approval of the 2nd generation TKI, the front line, which the first line treatment are effective in chronic myeloid leukemia, and this meta-analysis concluded that high-dose imatinib 600 or 800 was associated with higher toxicity and inferior efficacy as compared with the 2nd generation TKI, and also they concluded that nilotinib 300 mg was associated with superior efficacy, higher and sustained deep response rate as compared with the other TKI. And when we increase the dose to 400 mg, it will increase the chance of survival rate. And this is the recommended TKI doses in pediatric population for imatinib. They range from 260 to 340 mg per meter square once daily. For the dasatinib, it's 60 mg per meter square once daily. For the nilotinib, it's 230 mg per meter square per dose twice daily. And we can see here that they using nilotinib and dasatinib associated with earlier and deeper response rate compared to the imatinib. We can see that the percentage of patients who achieved major molecular response with nilotinib is 64%, with dasatinib is 52% compared to only 30% when using imatinib. But in addition to the efficacy and toxicity with different TKI in pediatric population, there are some issues that can guide us or that can control us to select the first line TKI according to the treating center. One of them is the drug availability, and we all know that the imatinib is the most widely used, and with more experience to its toxicity, also the easy administration, especially in pediatric population. For imatinib and the dasatinib, it's once daily and can be given with foods, while for nilotinib, it's twice daily, and we should be off foods 2 hours before and 1 hour after, and maybe this is maybe difficult in pediatric age group. Also the cost, especially in low and middle income countries, which is a big concern. We know that the generic imatinib is less expensive than the branded one, and all of the 2nd generation TKI are much more expensive than imatinib, so this is one of also consideration. The two schools of classification of definition criteria to respond to TKI therapy is the ALN and the NCCN guidelines, and simply the ALN got a different definition of response after different time points, 3 months, 6 months, and 12 months. And simply the optimal response is defined if we have below 10% at 3 months, below 1% at 6 months, and below 0.1% at 12 months. And the failure that if we fail to achieve complete hematological response at 3 months, this is failure. Or if we have a residual more than 10% at 6 months, this is failure. And if we have more than 1% to assess the gonadal function, especially for those who have delayed puberty or gonadal dysfunction during the TKI therapy. So the key points from this presentation, the treatment of Cml in pediatric population should be designed for cure rather than suppression of the disease. And hematopoietic stem cell transplant may play a role in the treatment of chronic myeloid leukemia in first chronic phase because it will provide a sustained remission by eradicating the leukemia stem cells. Also, the best result of hematopoietic stem cell transplantation using myeloablative conditioning with matched related donor using marrow source, and which is important while in TKI therapy, the regular assessment of response and the frequent patient awareness and adherence to TKI therapy are critical to maintain the optimal response in pediatric patients. And currently, all recommendations recommend that the continuation of TKI therapy indefinitely in pediatric patients with responsive disease, and the children on long-term TKI therapy should be monitored carefully for any endocrinal and gonadal function. Thank you.
Thank you very much for that talk. Any questions from the audience? Okay, thank you very much.
Thank you, Dr. Hanafy. I have one small question. Why, in your opinion, does the MUD, which is the matched unrelated donor transplant, has an inferior result from the sibling matched transplant? Sorry. Why, in your opinion, is the MUD, which is the matched unrelated transplant, has an inferior result in CML than the sibling match?
I think one of the major concerns about the matched unrelated donor is the transplant-related mortality. It is significantly higher than using matched sibling donor, so it will overcome the benefit of transplant in CML patients. So this is the main goal.
Dr. Hanafi, in second mutation events, okay, when I consider a patient in a secondary failure, what is the proper time to move the patient for transplant?
Actually, like I said, Mahmoud, in pediatric population, if you found that your patient, especially if for pediatric patients, because you don't know if this patient will progress to accelerated or blastic crisis, even if you initiated him on second line TKI therapy. So I recommend if your patient have resistance to first TKI and you prove that he has mutation that proved to be resistant to that TKI, to prepare your patient and to do donor search for this patient. Because like we said, there is a big difference between those who were transplanted in accelerated phase and those who were transplanted with blastic crisis. So to easily define those who maybe have poor response to TKI therapy and to subject them to hematopoietic stem cell transplant is better than to wait that till progression to accelerated or blastic crisis.
Thank you so much, Dr. Hanafy. We can move forward for the sake of our time. It's my pleasure to present our last speaker, Dr. Tdi, lecturer of Pediatric Oncology at Alexandria University, who will be presenting Foundation Medicine case presentation, and this is a Roche symposium.
In just a few minutes, I will present a case of optic glioma, of optic pathway low-grade glioma, and role of foundation medicine test that may help us and guide us to find more options for progressing relapsing cases. 4-month infant presented to us in April 2012 with proptosis of the right eye. MRI showed optic pathway glioma, and the patient presented with normal hormonal profile. This is the MRI of presentation. Showed the optic nerve glioma lesion, also hypothalamic lesion. We started induction chemotherapy of increased carboplatin protocol 10 weeks. MRI showed global regression of optic pathway lesion. So after this induction, we started the maintenance chemotherapy of increased carboplatin every 3 weeks, till total of 8 cycles, and the MRI shows further regression of lesion. But unfortunately, the patient presented with carboplatin toxicity in the form of hearing impairment in January 2013. So we shifted to another line, which was a weekly vinblastine. We received 20 weeks of vinblastine, then another progression occurred. Initially, there was a regression, but after 20 weeks, there is a progression. So we shift to TBCV protocol, thioguanine, procarbazine, CCNU, and vincristine for 8 cycles. All these periods, the MRI shows stationary course of the size and visual acuity. So we end the treatment here and start our follow-up in September 2014 till January 2019. MRI showed mild progression in optic chiasm lesion, but the same level of visual acuity. So we carried on follow-up. We didn't interfere this time, but in September 2019, there is a more and more progression in size of the bilateral optic lesions and brainstem and thalamic lesions, as shown in the MRI. So we advise to do a surgical biopsy of right optic nerve lesion. This eye was already no BL, but the other eye visual acuity was 6/16, 60. And the pathology revealed low-grade astrocytoma, grade 1. We did a foundation medicine test in this time and showed a BRAF V600E mutation and microsatellite status with stable, tumor mutational burden with low. And this is how the report of the case looks like. What about BRAF mutation? The 10-year progression-free survival of low-grade glioma patients with mutation is only 27% compared to 60% for patients with wild-type tumors. Of course, because we have a targeted agent for these mutations, this mutation is potentially predictive to start a treatment. So we advise to start dabrafenib and trametinib in December 2019 till now, with the patient more or less stable with some fatigue and some elevated liver enzymes. We started this treatment based on phase 2 open trial, evaluating role of dabrafenib in combination with trametinib in pediatric patients with BRAF mutation in high-grade and low-grade tumors. After 3 months of treatment, no deterioration of vision. The vision is stable, and MRI done this month showed stationary condition. So we will carry on more 3 months and reassess here. So what's foundation medicine? Foundation 1 CDX is a next generation sequencing based in vitro diagnostic device, for detection of substitution, insertion, deletion, alteration, and common number alterations in 324 genes and selected gene rearrangement as well as genomic MSI and tumor mutational burden using DNA isolated from formalin fixed paraffin embedded tumor tissue specimen. What the importance? The test is intended as a companion diagnostic to identify patients who may benefit from treatment with therapies in accordance with approved therapeutic products. How does it work? The doctor orders the test, a tissue sample from a tumor of a patient is taken, and a fixed sample is sent to Foundation Medicine. At Foundation Medicine, the DNA is isolated from tumor tissue section and then mixed with a reagent that specially detect and analyze DNA sequences. The patient sequenced DNA is then evaluated for the presence or absence of mutations. This figure shows the base substitution, insertion and deletion, copy number alteration, and gene rearrangement. We have three types of foundation medicine test. We have a foundation 1 CDX, use a tissue sample like our case, and we have a foundation 1 liquid using a blood sample for liquid biopsy, and we have a foundation heme for hematological malignancy. We have two types. In foundation medicine, it's a comprehensive genomic profiling. We test 300 mutations. This is in contrast with older tests which was using single biomarker testing and hotspot test to test one mutation. But foundation, it's a comprehensive genomic profiling. Thank you.
Any questions? We may have one or two maximum questions. If there's any. Yes, Dr. Gaida.
I am not trying to deny the results, but is this the result of the medication or the tumor removal by surgery?
The patient, before we start the new treatment, there is a rapid progression in size of the tumor. From February to September, there was a marked progression in the size of the tumor. And now we stabilize the condition, and I think it's a successful.
Okay, thank you so much, Dr. Khalid. And it's now time, I think, for a group photo and then for the lunch.
Thank you very much for staying late. We will have a group photo downstairs and then we will go for the lunch. We'll come back here at 5. We'll try to finish early because there is a big match. And I was asked by some people to see the match on this screen, but unfortunately we could not see it on the screen. So we'll come back at 5, please.